Okay. So let's start from aortic dissection, right? Okay. I'm gonna share my screen. Yeah. So for the aortic dissection, we don't have a TG guideline. Okay. For that, we have to use this guideline, life in the fast lane. We all know. If you are joining my sessions, you know about the life in the fast lane, right? Have you all watched previous sessions? So have you at least joined the live sessions? All done, right?
Yes, yes, yes.
Yeah, cardiovascular module is like a main part of AMC exam, right? Yeah, you should finish it. Yeah, so let's discuss about aortic dissection, okay? So what is the aortic dissection? So what happens in aortic dissection? Yeah, that's good, Dr. Ritik. Yeah. I remember you every day you are here, right? Yeah, that's so good. Yeah. Okay, so who can tell me what is aortic dissection? So what is happening there? So in aortic dissection, there's a tear in tunica intima, right? That caused the false lumor, right? We all know about the blood vessels, walls, right? So, if there's a tear in the tunica intima, and that can cause a false lumen in aortic dissection, especially due to the increased pressure of the walls. Okay, 1 minute. Sorry for that. Yeah. Or it could be due to weak aorta, like if the patient is having autoimmune disease, autoimmune vasculitis, Marfan syndrome, or like patient have aneurysm, they have like more prone to have aortic dissection. Okay, I'll show what is aortic dissection. What happen? Just for your knowledge, AMC doesn't ask about it. Dissection. This is happening, right? There's a tear in the inner wall that can lead to the bleeding into the this area and make the false lumen, right? False lumen. This is the aortic dissection. Okay. Remember, just for your knowledge. Okay, and you have to remember there's a classification, right? We have to remember Stanford classification. This is the most famous one. Usually in AMC they are asking from this classification. We don't have to remember D Baker, Sevens, and this classification. Just remember this type A and type B according to the Stanford classification. Okay, so what is type A? Type A mean the aortic dissection involving ascending aorta. Okay, it's involving ascending aorta and can extend distally infinitive. Okay, surgery usually indicated. I will show a picture. Okay, first we will discuss. Then type B usually involve aorta beyond left subclavian artery only. This is not the serious case. Type B we can medically manage with the blood pressure control. We all know like high blood pressure is a main risk factor for the aortic dissection, right? Okay, let's check what is this one. Yeah. So Stanford classification, type A here ascending aorta, and type B here you all can see, right? What about type C? Yeah, the same thing. Type B aorta beyond left subclavicular artery, and here involve ascending aorta. Just remember, okay? This is the serious one, type A. Uh, we must do the surgery for type A, but for type B, we can medically manage. Okay? Yeah. Yeah. So, here's the pathophysiology: atherosclerotic ulcer leading to the intimal tear, disruption of vasa vasorum causing intramural hematoma, and intimal tear can be seen. Okay, the same thing. So, then let's check about the signs and symptoms. Okay, so here the chest pain. Chest pain is classically ripping or tearing in nature. There's a severe sudden chest pain. Okay, usually in the questions they are given tearing in nature, tearing chest pain. Okay, I will show in emergency question in nature that occurs suddenly and is maximal at onset. However, chest pain is not always present. You should remember this as well. Okay, so this chest pain can be retrosternal chest pain. Okay, if it is the anterior dissection happen, it can be interscapular pain if it is in descending aorta, because we know there's a different places, right? So depending on the location, symptoms can be differentiate. Okay, so severe pain, worst pain, never, because this is a ripping, tearing, very severe pain. Okay, and sudden onset, sharp or tearing, migrating pain. This can migrate to the back. Usually, in exam, they are giving the tearing chest pain that can radiate to the back like that. Okay, remember these points. And other features, end organ symptoms, like it can be neurological. Sometimes it can cause the Horner syndrome, syncope, seizures, limb paresthesia, pain or weakness, flank pain, but these are not like typical symptoms. Okay, aortic regurgitation, hypertension, most have ischemic heart disease. Okay, we all know the main risk factor is hypertension. Yeah, and atypical presentation are also common. Okay, so consider the yeah. So what are the risk factors? As I already mentioned, inherited diseases like Marfan syndrome, Ehlers-Danlos syndrome, Turner syndrome, annuloaortic ectasia, familial aortic dissection. These are inherited diseases that can cause the aortic dissection. Okay, usually in as example, Marfan syndrome, there is a fibrillin gene mutation, and in here you all know about Marfan syndrome, right? There can be aortic root dilation, aortic regurgitation, those, and the uh, connective. This is a connective tissue disorder, right? Yeah, like that I'll explain once doing the connective tissue disorders. Okay, and aortic wall stress, hypertension, uh, 72%. 72% of the hypertension can cause the aortic dissection. Okay, previous cardiovascular surgeries, structural abnormalities like bicuspid valve, aortic coarctation, like infections like syphilis. Those can occur the tension in the aortic wall that can lead to the tear in this tunica intima. Okay. So these are the risk factors. Just remember about the Marfan syndrome and Ehlers-Danlos syndrome. Okay, sometimes they can ask from this. And reduce resistance of aortic wall, increase in age and pregnancy. Okay, so how we examine the patient? In here, features like aortic regurgitation is common, hypertension, shocking heart failure features, neurological features, um, SVC syndrome features because of the compression, okay, and asymmetric pulses, carotid brachial femoral, hemothorax, like that, okay. Yeah, and so what are the complications? Give me 1 minute. Yeah, sorry for that, doctors. Yeah. Okay. And so, what are the complications? So, aortic rupture can be seen, aortic regurgitation, acute MI, cardiac tamponade, end organ ischemia, death can be seen. Okay. So, let's go to the investigation. This is like high yield part for AMC. Okay. So, here you have to remember how to identify the patient when presenting with this chest pain, and you have to remember what methods of investigation, what methods of imaging we should use in here, and how we treat, because we have to identify type A and type B, or sometimes they are given in the question and asking for the management, okay, like that. So investigation, this is a chest pain, right? First of all, we have to do the ECG. Usually ECG is normal, or inferior ST elevations can be seen, right coronary artery dissection, okay. If it is in the coronary artery, because dissection can be in anywhere, right? So if it is occur in coronary artery dissection, we can see inferior ST elevation, but can be any STEMI, okay. 0.1% of STEMIs are dissections, okay. So these are ECG is not specific. Pericarditis changes, electrical alternance can be seen. We already discussed about this one, right? Pericardial tamponade. So in there we can see electrical alternance, right? Different height QRS complexes. Yeah. So ACG is non-specific in here. So in lab tests, leukocytosis, creatinine elevation, renal artery involvement, yeah, depend on the situation. Troponin can be elevated. D-dimer, if negative, dissection is very unlikely, okay, but not sufficient to rule out. Cross match, various biomarkers, these are not specific. This is the most important part. So imaging, okay. Chest X-ray. In chest X-ray, we can see widened mediastinum. Okay, wide mediastinum we can see. I will show an abnormal aortic contour, an aortic knuckle, double calcium sign more than 5 millimeter. I will show these features, and sometimes pleural effusion can be seen left side, tracheal shift, left apical cap, and remember these points, okay? Widened mediastinum, abnormal aortic contour, and aortic knuckle. And sometimes pleural effusion also can be seen when it's occur with the complications like pericardial effusion or cardiac tamponade. Okay, I'll show the, yeah, this is the, so here you can see the loss of contour in the aortic knuckle, right? And widened mediastinum, especially remember widened mediastinum, okay? Here you all can see, right? Prominent aortic arc, okay? Then mediastinal whitening. These are the main things you have to remember. Usually mediastinal whitening, okay? Remember this, and prominent aortic arc, that may loss of contour in here, okay? Like notch like something in here. You all can see, right? Not like something like that. You have to remember, okay? Because this is a kind of typical chest X-ray they are given in the exam. Yeah. Okay. Yeah, here. So chest X-ray is done. Okay, then echocardiography. Okay, echocardiography can be transthoracic or transesophageal. In transthoracic, 75% of diagnostic type A. Okay, we all know type A mean ascending aorta is involved. For that, 75% of diagnostic value in transthoracic echocardiogram. Okay, yeah. Like 40% in descending, like type B1. Okay. So can identify complications like aortic regurgitation, regional wall abnormalities, cardiac ischemia, and cardiac tamponade. What about transesophageal echocardiography? Much higher sensitivity specificity through operator dependent, needs sedation and is less available. Okay, so this is less available but useful in ICU, usually perioperative. We can use transesophageal. For upper ascending aorta and arc not well visualized. Okay, if the transthoracic echocardiography is not conclusive, we can go with transesophageal when we need it in perioperatively. Okay, and the next one, helical CT. Okay, useful screen for wide mediastinum. Never multiplane slice scanner may be now negate addition need for transesophageal or aortography to plan operative management. Okay, like most important one, the best one is the CT for here. Okay, for aortic dissection. So aortography was the traditional gold standard, delineating aortic incompetence and associated branch vessel involvement. Okay, now usually the CT is like main investigation, MRA, excellent sensitivity and specificity, but MRI or MRA is not the first line, right? This is kind of last option for most of the cases. Yeah, remember. So here they haven't given uh, some advantages and disadvantages for ECT, transesophageal, echocardiography, MRI, aortography. Okay. So CT, easy availability in emergencies, high sensitivity and high specificity. We can assess the complications, easier to monitor versus MRI, quicker than MRI. Okay. CT, the disadvantages are remote location, ideated contrast we have to use, can't assess in a LVFO, LVFO coronaries. Okay, 1 minute. I can't see this small. Yeah, there's a radiation exposure. What about transesophageal echocardiography? Bedside can detect intimal flap true and false lumen. Okay, aortic regurgitation, tamponade, like that. MRI, high sensitivity and specificity. Okay, aortography, detection of the intimal flap or aortic regurgitation. Okay, I know this is kind of too extra. You will get what they are asking in the questions. We will discuss some questions, okay, after the management. So, management. How we should manage these patients? Okay, we all know aortic dissection is an emergency case, right? So we have to follow the ABC pathway. Okay, and we have to control the blood pressure, control bleeding because there's a tear in the tunica intima. We have to do the fluid resuscitation if patient is hemodynamically unstable. Okay. So here we can give oxygen, we have to apply wide IV access, invasive monitoring, and we have to correct the coagulopathy, we have to control heart rate, blood pressure, and here the blood pressure aim is 100 to 120 systolic blood pressure. Okay. And in here we can give IV beta blockers like propranolol, esmolol or labetalol combined with vasodilators like GTN, labetalol, like that. Okay. And start beta blockers first to avoid increased aortic wall stress from reflex tachycardia. Just listen, okay? I know sometimes it's hard to in here. There's no classification or anything like no separation. Just give beta blockers, do this and that, right? You will get to understand the questions, okay? So remember about the beta blockers and vasodilators like GTN here and call cardiothoracic surgeon. Okay. So what is the indications for surgery? You have to remember this. If the patient is having type A aortic dissection, okay, and persistent pain, branch occlusion, if there's a leak or continued extension despite optimal medical management. If patient can't control from the medical management, then also we have to go for the surgery. Okay, so intraoperative management, we have to avoid hypertension, fast, full, and forward dissection clamps. Maybe we don't have to know these things intraoperative. This is not our part, right? We are not operating as a junior medical officer for AMC here. Yeah, and this is all for the aortic dissection. Okay, let's do some questions. Then you will get a like proper idea. Okay. Okay. Yeah. And management here. Yeah, the same thing. Stanford type A surgical repair is a mainstay management. Stanford B medical management is a gold standard, although endovascular surgery sealing of the intimal entry tier offers potential management in the complicated case. As we mentioned again about the indications, right? If the medical management can't control it, we have to go with the surgical repair. Okay. For Stanford type A, surgical, B, medical management. If we can't control by medical management, then again we have to consider surgical management. Okay. Here in emergency, they have mentioned some points for the treatment. So, medical management and watchful waiting is the first line management of patients with Stanford type B aortic dissection. Okay, and the same thing. Okay, I'll show some questions. Okay, let's do some questions. 55-year-old man present to the emergency department. Okay, emergency department with 3-hour history of sudden onset and sharp chest pain. Okay, 1 minute. Yeah, sorry. So here, 55-year-old man present to the emergency department with the 3-hour history of sudden onset sharp chest pain. He feels sweaty and has difficulty to breathe in. His medical history include hypertension, for which he is currently taking perintrapil and atorvastatin. On examination, he looks unwell with a blood pressure of 100/75, pulse 105, temperature 36.5. Okay, and the respiratory rate 20 and SpO2 99. He has a soft diastolic murmur, and the rest of his chest examination is unremarkable. An ECG shows sinus tachycardia. Chest X-ray is performed. Okay, here is the chest X-ray. So which one of the most likely to diagnosis in here? Okay, give me 1 minute. I'll read the answers. You have to type in the chat. Oh, you can
Okay.
unmute. So, in here, what is most likely to diagnosis? Okay, pulmonary embolism, acute myocardial infarction, aortic dissection, tension pneumothorax, pericarditis. Yeah, this is aortic dissection, right?
Due to chest X-ray, yes, as you
Yeah,
said, like mediastinal widened and
yeah,
arch,
here,
aortic arch.
yeah, here you can properly see, right? The widened mediastinum, right? You can properly see aortic arc and everything. So with his sudden onset sharp chest pain, with these symptoms, we can diagnose it as the aortic dissection. Okay. So this X-ray demonstrates the widened mediastinum, and in combination with the chest pain, this indicates a likely diagnosis aortic dissection. Risk factors for aortic dissection include same thing we already discussed: Marfan, Ehlers-Danlos type, Ehlers-Danlos syndrome, hypertension, previous surgeries, infection, like that. Okay. The pain described as sudden, severe, and tearing and may radiate to the back or abdomen. It can also mimic the pain of an acute myocardial infarction. The diastolic murmur present is indicative of aortic regurgitation. We talk about it, right? As a complication, this can appear with
Yes.
aortic regurgitation as well, right? These are the points. So, which can occur with aortic dissection? Based on the Stanford classification, type A involves the ascending aorta and type B involves the aorta beyond the left subclavian artery. Okay, so like that, yeah. The same thing in here as well. Okay, let's see. I'm not sure I have marked down the answer. Okay, let's uh, yeah, discuss next question. Yeah, okay. So 50-year-old man present to the emergency department with sudden onset severe chest pain radiating through to his back. He described the pain as tearing in nature. He feels nauseated and is fearful for his death. He has no significant medical history and does not take any regular medications. On examination, he appears unwell with pulse rate 110, blood pressure 90 by 60 in the right arm, 90 by 60 in the right arm and 70 by 50 in the left arm. Okay, and the respiratory rate is 22, SpO2 98, and the temperature is 36.7. Heart sounds are normal with no murmurs. Chest is clear to auscultate. There are no neurological deficit. And ECG shows the sinus tachycardia with no ischemic signs. Chest X-ray show the widened mediastinum. Okay, so considering the most likely diagnosis, which one of the most accurate approximate the 1 year mortality rate if left untreated? Okay, I'm gonna tell the answers. You can type in the chat. So it can be 10%, it can be 20%, 50%, 70%, or 90%. What do you think if left untreated? What do you think? Just just type something. Okay, one doctor has 50. Okay, one other doctor has 90 answers. Mm-hmm. Okay. What do you think? Okay, let's check the answer. Okay, just remember this. Okay, so it is 90%. So, patient present with the classic features of type A aortic dissection, sudden onset severe tearing, chest pain radiating to the back, hemodynamic instability, differential blood pressure between arms, and widened mediastinum on chest X-ray. The absence of ischemic changes on electrocardiogram distinguish this from acute MI. Through both can present with severe chest pain. So 90% is the most accurate approximation of the 1 year mortality rate for untreated type A aortic dissection without surgical intervention. Mortality is extremely high, with most death occurring with first few days to weeks due to the rupture. So, cardiac tamponade or end organ ischemia. Historical data shows that's up to 90%. Okay, 1 year mortality in Stanford type A ascending aorta dissection, it can be 90%. Just remember this one, okay? Sometimes they can ask. Okay, interesting. That's a CT as well. Next question. Okay, here. A 68-year-old man present to the emergency department with 2 hour history of sudden onset tearing chest pain. Was between the shoulder blades. His history includes the hypertension for which he takes perindopril. On examination, he looks unwell with blood pressure of 160 by 100, pulse rate of 90, and temperature is 37.2. The rest of physical examination is unremarkable. He is given oxygen by face mask and ECG performed. Okay. So, which one of the following is most appropriate next investigation? CT coronary angiogram, MR coronary angiogram, percutaneous coronary angiogram, transthoracic echocardiogram, CT angiography of the chest and abdomen. They are asking most appropriate. What do you think? Type your answers. Why transthoracic? Why echocardiogram? Because the most sensitive one is CT, right? So we have to do CT.
Yeah, city,
Yeah, can
yeah,
you
sure, sure,
remember?
sure. Yeah, city, it was city, yeah.
Yeah. Yeah.
The doctor, they said it's like most appropriate next investigation. They didn't say that
But
what's the most
but they are
appropriate.
asking most appropriate, right? So that means CT because the high sensitivity and the high specificity, right?
All right.
Yeah. Because initial we can do the chest X-ray. Then they're asking between echocardiography and the echocardiography and the CT. The most appropriate one is CT, right? If the patient is unstable and we need to do the patient's unstable, then we can like do the bedside echo, right? Otherwise, CT is the first thing that has most like priority in here, like most appropriate, right? In here also, they are mentioned easy availability in emergencies, high sensitivity and specificity. Okay, so remember about CT. Okay, in here mainly. Yeah, yes, this. Okay, let's check the answer and read the explanation as well. Okay, here the CT angiography of chest and abdomen. So, this patient present with acute severe tearing chest pain radiating to the back, which is highly suggestive of aortic dissection, especially in the context of the hypertension. Sorry, what is happening? Yeah. Yes. The CT angiography, chest and abdomen is the most appropriate next investigation as it is rapid, widely available, and provide detailed information about the aorta and its branches, allowing for the prompt diagnosis and surgical planning. It is considered the gold standard for the diagnosis of aortic dissection. Just remember, okay? So then let's check Wiener transthoracic echocardiogram. Can sometimes detect proximal aortic dissection, but it is less sensitive than CT. So, especially for the distal dissections, and may miss important finding in the chest and abdomen. However, it is an option for patients who are hemodynamically unstable, right? We all know in the hemodynamically unstable patients, we can't do CT. In that case, we can do bedside echocardiogram. Just remember these points, okay? They're very important. Yeah. Okay, here they are telling us main thing. Acute severe tearing chest pain radiate to the back. Yeah, we all know it's aortic dissection. So CT angiography of the chest and abdomen is the investigation of choice for the suspected aortic dissection due to its speed and accuracy. Prompt diagnosis and management of the aortic dissection are critical to reduce morbidity and mortality. Yeah. Okay. Yeah, we have one more questions. So, 65-year-old man present to the emergency department with sudden onset severe tearing chest pain that radiate to the scapula. Okay. 1 minute. Yeah. He has a blood pressure of 110 by 75, respiratory rate of 12, pulse rate is 60. The following tests are requested: renal function test, D-dimer, ECG, chest X-ray, transthoracic echocardiogram. A diagnosis of descending aortic dissection, Stanford type B, is made based on elevated D-dimer, widened mediastinum on chest X-ray, and dissection flap on the transesophageal echocardiogram. There are no signs of end organ malperfusion with normal kidney function. CT angiogram is awaited. Okay. Then they are asking which one of the following is the next best step in management. So, what we can do in here? Immediate open surgery, thrombolytic therapy, watchful waiting, IV fluids and vasopressors, endovascular treatment. Okay, I'm repeating the treatment again. Immediate open surgery, thrombolytic therapy, watchful waiting, IV fluid and vasopressors, endovascular treatment. What do you think? Okay, let's check. Okay, so some doctor.
I guess we should wait maybe because diagnosis cannot
Yes.
be like confirmed by D-dimer. So we should wait for CT angiogram. That is why I choose
Yeah,
B.
and they are suspecting standard for type B, right? Stanford type
Yeah,
B1, type B that I already mentioned in the during the treatment. We can medically manage and watchful waiting and medical management is the treatment of choice, right? So here the watchful waiting is the answer. Okay. Here, so
sure.
watchful waiting is correct action to take in this case. Although the patient is hypotensive, the blood pressure is quite adequate, right? The patient is still stable, right? If it is like 90 or less than 90, that we can take it as unstable. So here still we can wait, right? As there's
Yes,
no
yes.
end organ malperfusion, hence the patient is considered stable. He does not need vasopressor support or IV resuscitation. At this stage, since their patient has Stanford B dissection, immediate surgery is not warranted, but medical management, if need, is priority. So, if the patient has a tachycardia and the hypertension, we can give beta blockers as well, right? As a medical management. Okay. Same thing. Medical management and virtual waiting is the first line management of patient with a Stanford type B aortic dissection. Yeah, that's all for the question. So let's take 10 minutes break and let's discuss next topic. Okay. Now the time is 8:43. I'll come back after 10 minutes. Okay, doctor. Okay, so let's discuss about aortic stenosis, right? Okay, so some doctors have asked about it. 1 minute. Mhm. Okay, let's share the screen. You all back, right? Okay, so
Yes, doctor.
yeah, okay, so aortic stenosis also we have two guidelines, okay? Like we don't have anything in the therapeutic guideline, just we have to follow these two. There's one, this is from 2024 and this is for 2023. Like both are almost same. Okay, so let's discuss about it. Yeah. So what is aortic dissection? Yeah, so what is aortic dissection? Sorry, aortic stenosis. I'm just sorry for that. Yeah. So what is aortic stenosis? Who can tell what's happening in here?
Actually, valvular heart disease in which there's a narrowing of the aortic valve.
Yeah.
Uh, uh,
Yeah, in here, we can see the narrowing of aortic valve. So usually valve disease, like there are two types, right? There's either it could be stenosis or regurgitation, right? Mainly, yeah, it could be stenosis and regurgitation. So yeah, I made this note from that guideline. So here, so in aortic dissection, sorry, aortic stenosis, yeah, what we can see is the narrowing of the aortic valve, right? That can cause the obstruction to left ventricular outflow, right? We all know aortic valve is the valve that aorta between aorta and left ventricle. So when it's blocked, the cardiac output is decreased, right? So in here, it can be due to degenerative calcified diseases in elderly or due to bicuspid valve. Usually, aortic valve is a tricuspid valve, right? But sometimes some patients can have bicuspid aortic valve. That also can be a cause. Less common rheumatic heart disease or rheumatic fever. Then after rheumatic heart diseases can be seen, but this is less common in here. But in mitral stenosis, it could be like the most common feature. Okay, so and radiation injury also can be seen. So here, severe untreated aortic stenosis carries a higher mortality. Okay, so within 2 years, 30 to 50% of the mortality. Okay, so we have to treat, right? We all know if there is a less cardiac output, uh, that can lead the huge danger in our body, right? So what are the symptoms? You have to remember this triad: dyspnea, angina, and syncope, right? Mainly, most common one is dyspnea. Okay, remember these three. This is the classic triad of this. So other features like reduced exercise tolerance, and sometimes there can be a signs of heart failure. Okay, and the main thing you have to remember about this murmur. Okay, sure. I have to compare these murmurs. In that day also, I told you. So who can tell me what is the murmur in HOCM, or hypertrophic cardiomyopathy, or hypertrophic obstructive cardiomyopathy? Who can tell?
It's actually a crescendo decrescendo murmur at the
Okay.
left lower border.
Okay. What about other features with other maneuvers? What can happen with Valsalva maneuver and stand in and squat in? What can happen?
With squatting, it becomes quieter, and with standing, it like increases in the resonance in the voice.
Yeah, you're correct. Yeah, and where can be felt in crescendo, decrescendo, murmur in HOCM?
At left lower sternal border.
Yeah, you are correct. Yeah, you have to remember, okay? Because the thing is, in aortic stenosis also, the in here we can see the crescendo, decrescendo murmur, okay? So, and this murmur can be heard in right side, okay? Remember, aortic right side, and the hypertrophic HOCM one is left side, okay? Just remember this. This is a good chart. Okay, you can remember. So let's discuss. Yeah, type of murmur. Okay, in here we can see the ejection systolic murmur. This is crescendo and decrescendo. Crescendo, decrescendo mean increase and decrease. Okay, ejection systolic murmur, because crescendo and decrescendo pattern can be seen in HOCM as well. Okay, it's due to the turbulent blood flow to the narrow aortic valve. Okay, because the valve is narrow, the blood has to go with the high pressure, so that can cause this ejection systolic murmur. So this is the characteristic of this murmur. So here the location right upper sternal border, usually second intercostal space. It can radiate to the carotids. Quality is harsh, rough, loud in mid systole. So in here also is to soft or single, and carotid pulse can be slow rising, like low volume. Carotid pulse is slow rising. Okay, remember this. And best patient position is sitting forward. Okay, because the cardiac output is less, right, due to these stenosis. And remember this, when the patient is caught in, murmur become louder, okay? But in HOCM, the murmur become what? Reduce, right? In the what is in the, sorry, got disconnected. Which topic? We are discussing, doctor, aortic stenosis. Yeah, okay. Yeah, so here, remember, when we do in squatting, murmur become louder in here. But in HOCM, you have to differentiate, okay? Because sometimes they argue with murmur and these maneuvers, then we have to identify it, okay? We did so much questions while doing the cardiomyopathies, right? If you don't remember anything, just watch the cardiomyopathy video, okay? Please don't forget this, okay? It's very high. So squatting, murmur become louder. When standing or valsalva, doing valsalva, murmur become softer. Okay, like, yeah, I have to remember these things. Okay, while doing maneuvers, what happened to the murmur, like that. Here, the same thing again. I have it. So investigation. So investigation, we have to remember the echocardiography is the first line. Okay, echocardiography is the first line. And we have to categorize aortic stenosis. This is from here. Okay, this one. Yeah, this is the category. This is the classification. Okay, aortic stenosis can be mild, moderate, or severe. Okay, so in sometimes they can give like peak velocity and the diameter. Okay, remember these two. If the diameter is more than 1.5, it is mild, and the peak velocity is 2.6 to 2.9. This is mild case. If the diameter is 1 to 1.5 and the peak velocity is between 3 to 4, that could be moderate one. Okay, if the diameter of aortic valve is less than 1 and the peak velocity is more than 4, that is severe one. You all can see, right, when the stenosis happen, the velocity has be increasing, right, because of the small and narrowing of this valve. There's a high pressure and high velocity gradient to pass through this stenosed one. So velocity is increasing from mild to mild, moderate to severe, then the diameter is decreasing. Just remember this too. Okay, you don't have to remember those things. If you can remember this one as well, mean gradient. As I remember, there's a question in eMedC. They have mentioned all these three parameters: peak velocity, mean gradient velocity, mean gradient pressure, and the diameter, valve diameter. Okay, like that. Here echocardiogram, you can see like this. You don't have to remember. 1 minute, yeah. So like that. So other tests can be ECG, because ECG for left ventricular hypertrophy, chest X-ray for cardiac size, CT calcium scoring if echo is unclear. Okay, so how we should manage? The management is only definitive treatment is aortic valve replacement. Okay, aortic valve replacement. For aortic valve replacement indications, you have to remember symptomatic severe aortic stenosis, severe aortic stenosis with reduced ejection fraction, severe high gradient disease, like mean pressure more than 40, velocity more than 4, and valve area less than 1. This is the point, this is the three criteria you have to remember. Okay, from here. First one, peak velocity and the diameter and mean gradient pressure. Please remember, especially in severe one. It's very easy, right? Velocity more than 4, pressure more than 40, and the diameter is less than 1. Yeah, you have to easily remember. At least remember in severe case, because this is the indication for the definitive treatment, that means surgical valve replacement. You have to remember, okay? Yeah, here decision may and the okay, yeah, and the type of valve intervention. Yeah, there are two types. Okay, I'll show. The two types are surgical aortic valve replacement and transcatheter aortic valve implantation. Okay, these two, transcatheter aortic valve implantation and surgical aortic valve replacement. So we have to select among the patients if we whether go with the surgical one or go with the transcatheter. Okay, so how we choose this? So let's check. And I'll explain it. And other than that, this part mentioned in the email. So, okay, aspirin monotherapy is the current recommendation regimen for antithrombotic therapy after transcatheter aortic valve implantation. This provided there are no specific indications such as atrial fibrillation. Remember, aspirin monotherapy is the current recommendation regime after transcatheter aortic valve implantation. Just remember this, okay? This is mentioned in the e-medicine. Yeah. So how we go with how we select if it is surgical or transcatheter. Doctors, give me 1 minute, okay? අනේ සද්ද නවතින්නේ නැද්ද? Hello, doctor. Sorry for that. Yeah, something happened with our car and there's a huge noise coming from that. Yeah, that's why I just muted. Yeah, okay, let's discuss. Still, you can hear it, right? I came to another place. Okay, it's fine. You all can hear me properly, right? Sorry for the background noise, something with the
No,
car.
it's okay. It's okay.
Yeah, sorry.
Yes, we can hear you.
Yeah, okay. So you have to remember this chart, okay? You have to remember this one. So patient with severe symptomatic aortic stenosis. So here the heart team evaluation, okay? They after evaluation, in here valve and vascular anatomy suitable for transfemoral transcatheter aortic valve implantation, okay? Then after that, you have to remember this point, especially 65 or 65 to 80 and more than 80, okay? So here, if the patient is less than 65 years and low risk for surgical aortic valve replacement, so we can go with surgical valve replacement. If the patient is between 65 to 80, we can consider either surgical or transcatheter. It depends on the individual risk assessment, okay? Because we had to assess his other comorbidities like that. It's depend. If the patient is more than 80 or unsuitable or high risk for surgical aortic valve replacement, then we have to go with transcatheter aortic valve implantation. Please remember that, okay? And this side, interventions unlikely to be beneficial. Here, we can do intervention, but in this side, we can't do intervention due to if it is the patient is elderly or significant comorbidities or poor functional status, then we have to go with the medical or palliative care. Like that, you have to remember this, okay? And you have to remember after this one, transcatheter aortic valve replacement, we have to give lifelong aspirin monotherapy as well. This is how this procedure is happening. Yeah, you don't have to know that. So yeah, so in here, what are the medical management? Can see the medical management here does not change the progression but can treat the comorbidities, okay? Like we can control the hypertension carefully. Start low dose, okay? Hypertension. Yesterday we discussed about the antihypertensive therapy. And ACE inhibitors are safe and may improve symptoms and lipid management, okay? Here, so statin therapy is not very useful, okay? In their stenosis, right? Not plaque, right? Yeah, here the aortic stenosis is calcific, not atherosclerotic. So statin does not slow the progression or improve the survival. So not recommended in here. So watchful waiting with serial echocardiography only for asymptomatic severe aortic stenosis. Okay, safe when patient has no symptoms. An ACE inhibitor, not the first line, may be used as example. Patient with hypertension, we can use ACE inhibitor like that. Yeah, beta blockers generally avoid or use cautiously because reduce heart rate and contractility that can worsen the cardiac output, okay, in severe cases and cause the bradycardia like that. Okay, yes, usually we can treat the comorbidities according to the comorbidity. Yeah, the same thing. Yeah. So then we have the next part. We have to monitor these patients. If the patient has a severe asymptomatic aortic stenosis, so echocardiogram every 6 to 12 months. If it is moderate, echocardiogram 1 to 2 years. If it is mild, every 3 to 5 years. Okay, and exercise testing only in the asymptomatic severe aortic stenosis. Okay, they are not asking about this, but just remember this monitoring how often we should do the echocardiogram to monitor these patients. There's some yeah, okay. So let's do some questions. Okay, I'm not sure I have marked the answers. Give me 1 second, I'll check from my iPad. Yeah, no, I haven't marked the answers. That's good. So let's solve this together. An 89-year-old man present to the emergency department after an, you all understand it, right?
Yes,
Yeah, okay. If you have
Yes.
any doubt, just you can ask, okay? So 89-year-old man present to the emergency department after an episode of syncope while climbing stairs. He felt dizzy and sweaty immediately before the episode. He reported 10 minutes episodes of exertional chest pain over the past few days. He has experienced increase in breathlessness on exertion and bilateral leg swelling over the past few weeks. He has no palpitation, nausea or vomiting. His medical history include aortic stenosis, hypertension and hypercholesterolemia. So his medications include hydrochlorothiazide and rosuvastatin. On examination, he appears pale. Vital signs within normal limit. Cardiovascular examination reveal loud systolic ejection murmur, maximal in the right second intercostal space. There are fine basal crepitation on chest auscultation and bilateral pitting ankle edema. So, which one of the following symptoms indicate the poorest prognosis? Leg swelling, dizziness, sweating, syncope, exertional chest pain. What do you think? Just type your answers. Okay, leg swelling. What about other doctors?
Yes, leg swelling, doctor.
Yeah, okay, let's check the answer, right? Because it is a heart failure symptom, right? Okay, yeah. So the answer is leg swelling, right? Answer is leg swelling. And here, if you know anything about aortic stenosis, only know differentiate. If you only know how to differentiate the from murmur, still you can identify the disease, right? Here, the loud systolic ejection murmur, maximum heard at the right second intercostal space, right? That's why you have to remember and find basal crepitations because of the heart failure. I think this patient present with the symptoms of heart failure as well due to the stenosis. I think. Let's check. This patient present with the multiple symptoms of severe aortic stenosis complicated by heart failure. The classic triad of symptoms: angina, syncope, and dyspnea. While all symptoms indicate the severe disease requiring intervention, the presence of heart failure carries the worst prognosis. So, leg swelling is the context. Present right heart failure, which indicate the end stage disease and carried the poorest prognosis. The development of heart failure symptoms suggest the left ventricle can no longer compensate for the severe outflow obstruction. Yeah. So here an aortic valve intervention is recommended in patients with symptomatic severe aortic stenosis or asymptomatic severe aortic stenosis with impaired left ventricular function and life expectancy of over 1 year. Pre-procedural testing include the transthoracic echocardiogram, routine blood test, ACG, coronary angiography, and cardiac CT scan. The choice of intervention is determined by the evaluating risk and benefit of the echo procedure, considering patient comorbidities and functional status. Okay, refer figure. Okay, there's a figure, but I haven't attached it. Okay, I didn't see it. So here the same thing, classic triad. Then you have to remember. Yeah, MC can ask like this kind of questions as well, right? So much details in here, and they're asking just simple thing. They are giving so much details in the question and asking just simple thing. If you know it properly, you can easily answer. So, 65-year-old man with symptomatic aortic stenosis is being prepared for transcatheter aortic valve implantation. So, apart from several syncopal episodes, he has steadily worsening dyspnea and is now breathless at rest. His only medication is ramipril. He will require a medication to minimize his risk of clotting for 3 months after the procedure. Which one of the following would be most appropriate? Warfarin, aspirin and clopidogrel, rivaroxaban, dabigatran. Type your answers. Now you know the theory, right? Yeah. Yeah, very good. Yeah. The answer is aspirin in patient undergoing the transcatheter aortic valve implantation. Recent evidence has shown that single therapy with aspirin monotherapy more effective than dual antiplatelet or additional anticoagulant therapies, provided the patient does not have any special indication for the anticoagulation such as atrial fibrillation. So in this case, single antiplatelet therapy with aspirin proved to be non-inferior in the prevention of ischemic event and superior in avoiding hemorrhagic events compared to dual antiplatelet therapy. Here, the dual antiplatelet therapy is not preferred in this case in patient who does not require anticoagulation therapy. Single therapy with aspirin more favorable. Okay. The same thing. We already read this part in the management part. Okay, I have added this part as well in the above management part. Okay, so next one. A 70-year-old man is found during a regular checkup to have late systolic ejection murmur at his right upper sternal border. that radiates to the neck. He does not have any dizziness or chest pain, but has been experiencing some shortness of breath after exercise. On echocardiography, he is found to have severe aortic stenosis with left ventricular ejection fraction of 45. Which one of the following is most appropriate plan of management? Aortic valve replacement, statin therapy, watchful waiting, ACE therapy, beta blocker therapy. What do you think, doctors? Okay. What is your answer? Let's check the chat. What about other doctors? We have 18 doctors in the session. Please type your answers. They're asking most appropriate plan of management and severe aortic stenosis with left ventricular ejection fraction 45. They have mentioned it is severe aortic stenosis, right? Yeah. Let's check the answer. Okay. Yeah, the answer is aortic valve replacement. Okay, is the most appropriate management in this patient because he has severe symptomatic aortic stenosis with reduced left ventricular ejection fraction. Once symptoms develop in severe aortic stenosis, the prognosis worsens significantly, with a higher risk of sudden cardiac death, heart failure, and rapid clinical deterioration if left untreated. Exertional dyspnea is an early symptom of left ventricular decompensation, indicating that the heart is struggling to overcome the fixed obstruction. Additionally, his left ventricular ejection fraction of 45% suggestive systolic dysfunction, which is class 1 indication for valve replacement according to the current guideline. Okay, so we know what is the treatment, and depending on his surgical risk and comorbidities, he may be candidate for either surgical or transcatheter aortic valve implantation. Yeah. Okay, let's move to the next question. The same thing. Okay, no, there's no questions, just only. Okay, there's a small topic, aortic regurgitation. Usually they're asking from aortic stenosis. Yeah, but for my note, I have added all the valve diseases. Okay. So we have time, just we can give it a look in aortic regurgitation as well. So we all know what is regurgitation. Regurgitation means backflow, right? So backflow of the blood from the aorta into the left ventricle during the diastole because of the aortic valve does not close properly. Due to this, the blood can flow back. Okay, so that is the regurgitation. So causes are kind of same: bicuspid aortic valve, rheumatic heart disease, infective endocarditis, aortic root dilation, usually in the Marfan syndrome. There's a very high part, aortic root dilation in Marfan syndrome. Usually they're asking about this aortic root dilation. Or it can be due to the aortic dissection as well. We discuss aortic dissection, right? With aortic regurgitation. So, symptoms are exertional dyspnea, fatigue, palpitations, or awareness of the heartbeat, initial palpitation, fatigue, exertional dyspnea, angina in severe cases. So, acute case, sudden shortness of breath and pulmonary edema also can be seen. So, signs are wide pulse pressure, water hammer pulse, like collapsing pulse. We know about water hammer pulse, right? And the displays forceful apex beat can be seen in here, and early diastolic decrescendo murmur at left sternal border. Louder in leaning forward. Please remember this point, okay? This one you have to remember. Okay. Early diastolic decrescendo murmur at left sternal border. Okay, in aortic stenosis, it's in right sternal border, right? Upper sternal border. Yeah, investigation the same. Echocardiography is the first one. Then we can do the ECG, chest X-ray. So management, we have to control hypertension, especially with vasodilators, regular echocardiogram monitoring for left ventricular size and ejection fraction, aortic valve replacement when symptoms appear or left ventricular function is deteriorate. In acute severe aortic regurgitation is an emergency that require urgent surgical assessment. Okay, remember this as well. Usually they are not asking about the management and everything. Usually they are asking like they are asked us to diagnose it. Okay, let's check the questions. Okay, and so this is like they haven't mentioned anything properly for aortic regurgitation. Like there's no proper guideline for it. Okay, so here let's check these questions. So 22-year-old man present to the GP clinic for routine checkup. He has no significant medical history and take no regular medications. On examination, he appears well. His pulse rate is 72, blood pressure is 150/60, respiratory rate is 14, SpO2 98, and the temperature 36.6. He is notably tall, 198 centimeter, with long, slender limbs and fingers. His arms span exceed his height by 8 centimeter. He has mild scoliosis and high arched plate. Cardiovascular examination reveal a murmur. So, which one of the following most likely murmur associated with this patient condition? So, what is the diagnosis of this patient?
Marfan syndrome.
Yeah, it's Marfan syndrome,
syndrome.
right? Usually, they are asking question about aortic regurgitation and aortic root dilation with Marfan syndrome. Okay. There's I think like 5 to 6 question in Marfan syndrome, and that can like explain everything about it in the email. See, so here,
But doctor, that aortic stenosis maybe is also related with the Marfan syndrome as well.
yeah, but mainly aortic regurgitation, doctor. This one because the Marfan long bones heart dilation due to aortic root dilation because of the valve can be like separate from the actual distance that can cause the regurgitation because of the
Both
root dilation.
both.
Yeah, both can be present, but mostly aortic regurgitation, doctor. If you can do the Marfan syndrome questions, you can easily like understand. Okay, let's check the answer. Okay, yeah. Here, the patient present with severe clinical features suggestive of Marfan syndrome, including tall, long limbs, long slender fingers, arm span exceeding height, scoliosis, and high arched palate. So Marfan syndrome is autosomal dominant connective tissue disorder causing the mutation of fibrillin 1 gene. Okay, in Marfan syndrome, the most common cardiovascular manifestation is progressive dilation of the aortic root. Because of that, it can lead to the aortic regurgitation. Please remember that. Okay, in Marfan syndrome, the main aortic pathology is aortic regurgitation due to the aortic root dilatation. Okay, due to the aortic root dilatation. Okay, the murmur of aortic regurgitation is typically a high pitch blowing diastolic murmur heard best at left lower sternal edge. Left side lower sternal edge. The wide pulse pressure in this patient also support the presence of aortic regurgitation. Like wide pulse pressure, the water hammer pulse. Okay, yeah. And here the aortic stenosis is not typically associated with Marfan syndrome. It could be, but it is not typically associated. In here, this is the narrow vein, right? In usually Marfan syndrome, there is a aortic root dilatation. Due to that, regurgitation can occur due to the valve dilation, right? Remember like that with the pathophysiology, then you won't forget it. Yeah, like that. The same thing. Marfan syndrome associated with aortic root dilatation, which can lead to the aortic regurgitation. The key features of Marfan syndrome include tall stature, long bones, arachnodactylity, and lens dislocation. So, echocardiography is important to investigation the patient with suspected Marfan syndrome to assess for the aortic root dilatation and valvular abnormalities. So, yeah. What is this, doctor? Okay.
Doctor, I saw one question in e-medicine for the Marfan syndrome, but question is very clear, like fifth intercostal space. So that is the answer is the mitral regurgitation. That's why I share here.
Mm,
E-medicine.
what is here? The online percentage to the check. Paransystolic murmur heard best at fifth intercostal space. He is otherwise a tall, thin, healthy man, although does have a history of several spontaneous. Which one of the following valvular pathologies is most likely cause this murmur? Choose the single best answer. Here, doctor, they have given the pansystolic murmur, right? Not
Yes, and
diastolic.
they given the fifth intercostal space also.
Yeah, doctor,
Mid-clavicular
that
line,
is
yeah.
that is specific for the
Hmm.
here the mitral regurgitation. Okay, so
Yeah, I
because
know.
of
Just I share already if it is
yeah,
like in Marfan's, there is a regurgitation both common, mitral also and aortic regurgitation like this.
yeah, doctor, yeah. Anyway, due to the dilatation, right, can be caused, but stenosis is different, right? It's less typical. Yeah, you're correct. Because of the in this question they are explained about the mitral regurgitation murmur. Okay, that's why we go with that answer, because they are explained about in the fifth intercostal space like that. Okay, it's depend on the question, but mainly you have to remember the most common one is this one, aortic regurgitation due to the aortic root dilatation. Okay, the most common one. Okay, like that. Okay, so let's do next question. You can give it the read in the question in the chat also. So, a 50-year-old woman present to the general practitioner with breathlessness on minor exertion. She has no significant medical history and does not take any regular medications. On examination, she appears well. Her pulse rate is 88, blood pressure is 140 by 60, respiratory rate 16, SpO2 98, temperature 36.7. She has a wide pulse pressure. Remember the word wide pulse pressure, right? And the cardiac auscultation revealed an early diastolic decrescendo murmur best heard over the second right intercostal space on expiration. Echocardiography level reveals a left ventricular ejection fraction of 38. So, which one of the following is most appropriate therapeutic intervention? So, aortic valve replacement, annual clinical assessment, 6-month echocardiography, nifedipine, ramipril. What do you think, doctor?
Aortic wall replacement.
Yeah, what
Because
about other doctors?
Yeah, aortic valve replacement.
Yeah, right. Okay, let's check the answers. So, aortic valve replacement is indicated in the patient because she has symptomatic severe aortic regurgitation with evidence of left ventricular systolic dysfunction, ejection fraction below 50. Surgery is recommended to prevent further irreversible left ventricular damage and to improve the symptoms and long term survival. The presence of exertional dyspnea and reduced ejection fraction are both clear indication for surgical intervention, as medical therapy alone cannot correct the underlying mechanical problem of the regurgitant valve. Right? So, symptomatic severe aortic regurgitation with reduced ejection fraction require prompt aortic valve replacement to prevent the reversible left ventricular dysfunction. Medical therapy does not address the underlying medical problem in severe aortic regurgitation with left ventricle dysfunction. Yeah. Symptomatic severe aortic regurgitation carries a poor prognosis without early intervention. Okay, let's do. Sorry, you saw the answer, right? It's okay. Let's do next question. 24-year-old man present to the GP clinic with 6-month history of back stiffness and pain. He has also noticed eye pain and blurred vision. Okay, blurred vision. There have been no changes to his bowel or bladder habit. He denies history of intravenous drug use. He has a medical history of asthma, diagnosed last last year, for which he take regular budesonide formoterol. On examination, he appear with normal limits vital signs within normal limits. A diastolic decrescendo murmur is present, loudest as left lower sternal edge. Which one of the mostly likely diagnosis? Ehlers-Danlos syndrome, aortic dissection, vertebral compression fracture, ankylosing spondylitis. Yeah, what is the answer? What do you know about this disease? Back pain? What do you think about the answer? Okay, patient has the 6-month history of back stiffness and pain, and notice eye pain and blurred vision, anterior uveitis, back pain and back stiffness more than 45 minutes. And what about others? Yeah. And the patients having asthma. What do you think about ankylosing spondylitis? Who know about ankylosing spondylitis? Look, this how, like, this is the way AMC mostly focusing on like aortic regurgitation, right? No direct questions, only like few questions in emergency as well. So here the patient is presenting with ankylosing spondylosis and with the regurgitation. Okay, let's check the answer. The most likely diagnosis in this case, ankylosing spondylitis. This is the chronic inflammatory condition typically present in young adults. Okay, this is the seronegative spondyloarthritis, right? We have seronegative 4 types. One of which is ankylosing spondylitis. I'll explain once doing the rheumatology, okay? So, with insidious onset of low back pain and stiffness lasting more than 3 months. The patient's age, duration of symptoms, and pattern of back pain are consistent with this diagnosis. And here, two extra-articular manifestations support the diagnosis. Ankylosing spondylitis in this case. First, the eye symptoms suggest the anterior uveitis. Second, the diastolic decrescendo murmur at the left lower sternal edge, consistent with aortic regurgitation, a non-cardiovascular complication of ankylosing spondylitis. Please remember this, okay? The cardiovascular complication from ankylosing spondylitis is aortic regurgitation. Okay? Yeah. So the next one is mitral stenosis. So what is mitral stenosis? We all know stenosis means narrowing, right? Mitral stenosis is narrowing of the mitral valve. So where is the mitral valve located? What is the location of mitral valve?
Left atrium, left ventricular.
Yeah.
Left atrium, left ventricular.
Left side, right? Left side between atrium and ventricles. Ventricle, left one. So this can lead to the obstruction of the blood flow from left atrium to left ventricle, and this causes raised left atrial pressure and pulmonary congestion, right? We all know due to the high pressure that can increase the left atrium pressure, then pulmonary veins pressure, then it can lead to the pulmonary congestion. Due to the increased pressure, this circulate to the lungs. Okay, that's the cycle how we can see the pulmonary congestion in the mitral stenosis patient. So causes here, how to remember rheumatic heart disease is the most common cause in Australia. Okay, so remember this one, especially in uh, indigenous population. Okay, so less common is severe mitral annular calcification, congenital lesions, previous valve surgery. So symptoms are exertional, shortness of breath, reduced exercise tolerance, orthopnea, fatigue, hemoptysis due to pulmonary hypertension, right? And the palpitation due to the atrial fibrillation, okay, can be seen. You shall remember the exertional breathlessness, reduced exercise tolerance, orthopnea, fatigue. Those are the main symptoms. So signs here, the diastolic murmur at the apex, right? At the apex of the heart, so low pitched diastolic murmur at apex of the heart, and we can see opening snap after S2, and loud S1 also we can see, and the signs of pulmonary hypertension, and sometimes it can associated with the mala flush in the rash. Okay, we all know about the mala rash, so we can see the flush in face in patients. Remember this murmur, diastolic murmur at the apex. So complication, atrial fibrillation, pulmonary hypertension, right heart failure, thromboembolism, pulmonary edema can happen. Okay, so echocardiography to confirm the severity is the first line for all the valve diseases. Okay, so here also there's a severity, okay, severity classification, but you don't have to remember everything. Just simply remember mild mean more than 1.5, moderate 1 to 1.5, severe less than 1 square centimeter, very severe mean less than 0.7, 1.5, 1 to 1.5, less than 1, less than 0.7 cc, right? Just remember about the severe one. If it is less than 1, it's already severe, like that. Okay. So here you have to know this point, okay? You have to know how we manage these patients. There is a score, Viking score, okay? We don't have a proper guideline for this one. I got this details from the e-medicine, this one, okay? I'll show the question because usually now AMC asking from e-medicine, right? Yeah. So here the rate control for atrial fibrillation, right? We all know we have to control the rate, and anticoagulation. Warfarin is preferred in mitral stenosis with atrial fibrillation. So diuretics for congestions, we have to symptomatically treat the patient, okay? And we have to remember this one, percutaneous balloon mitral valvotomy, okay? Remember this, I'll explain why. Percutaneous balloon mitral valvotomy, you have to remember this one. And mitral valve repair or replacement in severe cases, okay? And so what is my Viking score? So Viking score mean it's the patient's this stenosis categorized according to the mobility, thickening, calcification, and subvalvular thickening. Okay, according to that we are classifying it. Okay, like that. Yeah, sorry for that. Yeah, like that. You don't have to remember this. Okay, you just have to remember the score. Here, the Viking score assesses the valve morphology based on 4 parameters: leaflet mobility, thickening calcification, and subvalvular involvement. Each parameter is scored from 1 to 4, with the highest score indicating more severe pathology. A total score is more than 8 generally predict poor outcome with balloon valvoplasty, making surgical valve replacement is a preferred option. So you have to remember about this 8, okay? 8, the total score. Because if it is less than 8, we can go with this balloon one, okay? Balloon valvoplasty. If it is more than 8, there's no effect of this. So we have to surgically replace the valve. Like that, okay? The same. Here, if it is less than 8, best for the balloon mitral valvotomy. We call it PMBV, okay? Here, if it is score 9 to 11, PBMV, like balloon mitral valvotomy, may be possible, but it's depend on the situation, okay? Not sure, but if it is more than 12, we can't give it, okay? Just remember 8, less than 8, good for balloon mitral valvotomy. More than 8, we have to go with surgical replacement, yeah. Okay, let's do some questions. So 62-year-old woman present to the GP clinic with progressive exertional dyspnea over 6 months. She has rheumatic heart disease diagnosed in childhood. She takes warfarin and metoprolol. On examination, she appears short of breath on minimal exertion. Her pulse rate is 85 and irregular. Blood pressure 110 by 70. Respiratory rate is 20, SpO2 96, and temperature 36.8. Cardiac examination revealed the opening snap and mild diastolic murmur. Chest examination revealed fine bilateral basal crackles. So transthoracic echocardiogram shows the several severe mitral stenosis with valve 1 square centimeter. Mean gradient 12 and significant leaflet thickening with heavy calcification and subvalvular involvement. The Viking score is calculated as 10 out of 16. So which one of the following of the most appropriate management? direct current cardioversion, surgical mitral valve replacement, medical management with diuretics, increased metoprolol use, percutaneous balloon mitral valvuloplasty. What do you think?
Surgical mitral valve replacement.
Yeah, you got
Because
the
it is
point,
more
right?
than 8. Yeah.
Yeah, you got the point, right? That's how we answer. Even if we if we didn't do these questions for the mitral stenosis, we don't know about the Viking score, right? But in the exam they can ask because they are directly taking questions from the emergency. And so you have to like target the emergency more, okay? Like that. Yeah. The same thing. Yeah, because there's no proper guideline for mitral stenosis. Yeah. Okay. So let's discuss mitral regurgitation. Okay, so here. So what is mitral regurgitation? We all know regurgitation means backflow, right? So backward flow of blood from left ventricle to left atrium during systole. So most common valvular disease in Western countries Western countries, including Australia, especially in older adults. Untreated mitral regurgitation can lead to the progressive left volume overload, then heart failure, and death also can be occur. So what are the causes? Of mitral regurgitation? Okay, so structural abnormalities can be seen in some cases like degenerative diseases, rheumatic diseases like thickened leaflet after rheumatic fever, after endocarditis, and annular calcification, usually in elderly, rare radiation, drug systemic diseases can be seen. Remember this one. Just rheumatic disease, endocarditis, and the calcification in elderly people. Okay. So secondary one, the functional one. These are structural causes. So what are the functional causes? Right ventricular dilation from the ischemia or non-ischemic cardiomyopathy. We all know due to the cardiomyopathy it can cause a regurgitation, right? So here left ventricular dilation from ischemic or non-ischemic cardiomyopathy, long-standing atrial fibrillation, like that. Okay. So, what are the clinical features? Usually, often asymptomatic in early due to due to left atrium enlargement accommodating the regurgitant volume. Usually asymptomatic. Okay, due to the left ventricular enlargement accommodating the regurgitant volume, because there's a regurgitation and backflow of some blood and that can accumulate in left atrium. Okay, left atrium first. So exertional dyspnea, fatigue, palpitations, orthopnea, these are the symptoms. So what are the signs? Here you have to remember the pan-systolic murmur at apex, okay? And that previous question, the one doctor shared, in that also I told they are mainly focused about this murmur, right? Pan-systolic murmur. So in that case, we have to go with mitral regurgitation, right? In mitral regurgitation, pan-systolic murmur at apex. Just remember like that. If it is mitral, the usually murmur in apex, right? And the displays forceful apex beat downward and outward. And anterior leaflet pathology radiates to axilla. And posterior leaflet flail radiate to anteriorly. You don't have to remember, okay? So mitral regurgitation murmur, okay? So pan-systolic murmur, this is from that huge table I showed in the earlier in the class, okay? I have cropped it and attached here. So pan-systolic murmur maximal at the apex that radiate to the axilla. late systolic murmur in the presence of mitral valve prolapse. And hand grip makes the murmur louder. Apex beat is displaced downward and outward, forceful in character. Soft first heard sound. Presence of third hard sound is common. And S3, usually in here also mention S3 and short mild dystolic murmur, significant primary one. Just remember these points. The first thing, displayed forceful apex beat, parasystolic murmur at apex, and it can radiate to the axilla. Okay. Yeah, in advanced disease, we can see the cardiomegaly, signs of heart failure. So diagnosis, we all know. First line is transthoracic echocardiogram. Okay. There's no proper guideline, but there is a Australian some article and they have mentioned about this. Okay, I'll show it. If you want, you can go and read it. Meditation. I got from this one. Yeah, this one. If you want, you can read, okay? This one. I made my note from here. Okay? From this one. If any case you want, you can go and read, okay? It's kind of hard to read, right? That's why I'm like taking so much time to read in each and every point and make these notes, okay? Yeah, I know it's very hard to read each guideline and everything. Okay.
Yeah, a lot of information.
Yeah, doctor. And that's why like I have to charge some amount for my notes. Even yesterday I posted and some doctors ask and buy from me notes. Yeah. Because I really need to like give a proper one with the clear guidelines, right? Otherwise, because even some courses I already saw some notes and everything, they are so incomplete. There's no guidelines, no questions. I don't want to give like those kind of notes. That's why like I'm taking so much time and effort. If you want, you can see here. This is the guideline. I got it. Okay, everything from this topic for the mitral regurgitation. In this chart, they have mentioned the first line is transthoracic echocardiogram. Okay, to assess the severity mechanism due to if it is primary one, that's a structural one, or secondary one, functional one due to some other disease. Okay, and to find the left ventricular function, left atrium size, and pulmonary pressure. But in that article, they have mentioned the gold standard one is transesophageal echocardiogram. Okay? Because it necessary for full anatomical assessment. Okay? Due to 3D transthoracic transesophageal echocardiogram accurately localize the leaflet. Okay, leaflet exact area, exact location of the leaflet. Okay, so essential for pre-surgical and like pre-TT. I will explain in the treatment. Okay, what is this? Okay, for the pre-operation, no, we need transesophageal one, but for the initial we can do transthoracic echocardiogram. Other intervention we can do the cardiac MRI, but it is not always first. Coronary angiography and this kind of thing. Okay, so management depend on the type, severity, symptoms, anatomy, like that. Okay, this is the chart I got from here. Yeah, where is it? Here. Okay. Yeah, so here how we treat. Okay, the same thing from the chart. Okay, here. So primary one. Medical therapy. So acute mitral regurgitation We can give diuretics due to the pulmonary congestions and inotropes as if we need. Okay, and this is like a symptomatic treatment. So chronic stable mitral regurgitation with preserved ejection fraction. So there's no need of chronic stable MR with preserved ejection fraction, no role of medical therapy. Mitral regurgitation with reduced ejection fraction, that we have to treat it as the heart failure, right? Who can tell me the four main drug classes for heart failure? Hurry up.
ACE, ARNI, SGLT2, mineral glucocorticoids, and was it beta blockers?
Yeah, and SGLT2
Inhibitors, yeah.
Yeah. You have to remember, when I ask what are the four classes, you don't have time to think, okay? You just said like it should be, you don't have time to think, okay? In the exam, because for one
Sure,
question you will get 1 minute. Within 1 minute you have to read. While reading you have to diagnose the situation, and within 1 minute you have to do everything, okay? Like that. So what are the indications for interventions if it is severe mitral regurgitation with symptoms, severe mitral regurgitation with left ventricular dysfunction, new atrial fibrillation, large left atrium? Usually I didn't see about this, asking about this part, but I just added from that article, okay, just in case. So preferred treatment, the surgery is the first line. Okay, if the patient is need the indication interventions, so surgery is the first line. So mitral valve repair is preferred, better survival and durability than replacement. Mitral valve repair, okay, replacement if repair is not possible. Okay, and transcatheter H to H repair, this is the TEER. This is the repair one. Okay, we called it TEER, transcatheter H to H repair. For severe primary MR, prohibitive surgical risks. Okay, we can go with the transcatheter H to H repair. In these cases, the evidence show the improvement in symptoms and quality of life. So secondary MR. Secondary one, we can because due to some other diseases, so we have to treat that, like medical therapy first line, guideline directed heart failure therapy. Okay, we know about how we treat the heart failure patients, cardiac recontrainization therapy for suitable patients, treat underlying cardio-atherosclerotic diseases, like that. Secondary mean always secondary to some disease or something, so we have to treat the cause, right? Treat the disease, then it will eventually decrease the situation. Yeah, like that. Yeah, and we will do one question, and it's already 10, right? More than 10. Yeah. So 72-year-old man present to the cardiology clinic with 6 months history of progressive shortness of breath. He has severe mitral regurgitation and left ventricular dysfunction with an ejection fraction of 25%. He has a medical history of ischemic cardiomyopathy and atrial fibrillation. His medication include bisoprolol, spironolactone, furosemide, sacubitril valsartan, and dapagliflozin. He's already taken four types of drugs, right? Four class of drug for the heart failure. He has a cardiac recontrainization therapy for defibrillation in situ. On examination, he appear shortness of breath at rest, pulse rate is 75, blood pressure 110 by 70, respiratory rate 24, SpO2 94 on room temperature, and 36 room temperature is 36.5. Cardiac auscultation reveal grade 4 out of 6, pan systolic murmur maximal at the apex radiate into the axilla. So chest examination revealed bibasal crackle. There is a mild pitting edema to the ankle bilaterally. So which one of the following is most appropriate next step in management? Heart transplant assessment, increased furosemide dose, palliative care referral, transcatheter mitral valve repair, surgical mitral valve replacement. So what do you think, doctors?
Surgical mitral valve replacement.
Yeah, what about other doctors? Help your answer. So one doctor said is surgical mitral valve replacement. So what about other doctors? Okay, let's check. B. Let's B. Okay. B. Oh no, sorry. E. Okay. Some doctors said E, D, and E. Yeah. Okay. Let's check the answer. Okay. And you will get a point. So the answer is transcatheter mitral valve repair. Okay. Here, this patient has severe mitral regurgitation with significant left ventricular dysfunction that remains symptomatic despite optimal medical therapy, include maximum dose of the guideline directed medical therapy, this heart failure therapy, and cardiac recontrainization therapy. The next appropriate step in management would be consider of the interventions. Okay. Here, transcatheter mitral valve repair is an appropriate option for patients with severe mitral regurgitation who remain symptomatic despite optimal medical therapy and who are high surgical risk. This procedure involves the place in a clip to bring the anterior and posterior mitral leaflet together to reduce the regurgitation while avoiding the risk of open surgery. So venous surgery carries a significant risk in patients with the severe left ventricular dysfunction and multiple comorbidities. Okay, in here also. Here the mitral valve repair is preferred. Okay, repair is preferred. Replacement if repair is not possible. Okay, get the point, right?
Yeah, what can be cases of no repairment then?
Yeah. Sorry, doctor.
I mean, I'm asking like replacement if repair not possible. What will be cases of repair when it's not
If
possible?
the repair is not possible, we have to replace the full valve. Here, my replacement if repair is not possible. So here the surgery means the mitral valve repair. Okay, here the first thing, mitral valve repair is preferred, better survival and durability than replacement. Okay, first we have to do the repair one. We can do the repair. If it is fail, then only we can go with the mitral valve replacement, like that. Okay, got it right?
Got it. Yeah, got it. Thank you.
That's here. Catheter edge-to-edge repair is an option for severe mitral regurgitation in patients with high surgical risk. Optimal medical therapy and cardiac recontrainization therapy should be trial before considering intervention procedure. Okay, our patient is failed that medical therapy because this patient's mitral regurgitation from the heart failure, right? So we treated it and recontrainization, everything failed. Then we have to go with the intervention, the secondary case. Yeah, the left ventricular dysfunction with severe mitral regurgitation carries a poor prognosis without intervention. Yeah, that's it for today, doctors. And do you have any problems or anything? You can just ask. You all
No,
get
it's
the
okay. Thank
points,
you very
right?
much.
Yeah.
Yeah.
And okay, there's a problem. Doctor, during your MCQ exam, can you remember roughly how many questions are similar from? I think, doctor, so much questions came from e-medicine, like similar questions. Yeah. Like as example, yeah, I can't tell the example. Like most of the questions are from e-medicine. Like there's a trend, okay? In August, like 60% from e-medicine, like same question. And usually after August, they are given all the pictures from e-medicine, right? All the pictures from e-medicine. And okay, October, the August, there are 60% from like approximately 60% of questions from the e-medicine direct question, okay? Then after September also same. Most of questions came from August. And the September question exam was like good than August. But in October, there are less amount of e-medicine question, like exact same questions, okay? But some kind of some kind of few amounts of questions, like most related one, but not the exact question. But in the November, some of questions came directly from the e-medicine. Like as example, there's a question for the transient synovitis in the children, okay? Because for the transient synovitis, we are not doing any intervention, we are not doing any investigation. So exact same question, like as I remember, 8-year boy something. If you want, you can go and check. 8-year-old boy, something like that. The recaller gave the same stem and the same question in the e-medicine as well. Yeah, because I remember I sent this question to Dr. Haru, like Dr. Haru, because I saw the same question in e-medicine. Then I sent Dr. Haru to like compare this exact question. That's why I remember that one. Yeah. There's no textbook for the textbook for the AMC, doctor. Please don't follow the John Murtagh. That's a waste of time. If you want, like, if you want to read that huge book, you can, but it's not updated. You have to read the guidelines, like therapeutic guideline in the group. Also, I have shared the document mentioning the all the guidelines. Main thing is therapeutic guideline, because therapeutic guideline cover like most of medicine part and some of gynecological part and some of surgical part as well, and the emergency medicine like toxicology, everything is we are covering from the therapeutic guideline. And for the surgery, for some topics we can't find proper guideline because there are no guidelines for that. For that, we have to use updated guideline, like up to date, like that. But my preference is, if we don't have any proper guideline, better to do e-medicine questions and learn theory from it, like that. Okay, and psychiatry also included in the therapeutic guideline. And for the pediatrics, we all know RCH, and you have to remember uh, school exclusion criterias and immunization. Okay, immunization chart. Mm, yeah, those are the main things. And for the orthopedics, we can use the orthobullet. Yeah, and for the STIs, we have to use the STI Australia. And some diseases are included in TG as well. Infectious diseases also, most of them included in TG. And the TG is the main thing you have to follow, doctor. There's no for AMC, there's like no exact syllabus, but we have high yield topics. As example, the like every month they are like popping up, so we have high yield separated topics. So that's what we are covering, high yield topics for the AMC. As example, when I also doing the topics, I'm telling this is high yield like that, because they are usually in every month they are popping up in the exam, like that. I making a list and I'll share it in the group. I have my own list that I use for my preparation, but it's not very clear. I have one handwritten one, so I have to make a proper one. Yeah. No, doctor, don't do this one, Fisher 100. I also heard about it, please do the e-medicine. I think 120 e-medicine questions for ethics. Even for me also, I did that part, and I have read the AFRA guidelines as well. If you can do that 120 medicine ethics, you don't have to worry. Actually, once you are doing it, you will eventually remember everything. Please don't waste time for other guidelines or other things. I think better stick with the Australian things only, because in e-medicine also they are updating every day. Not every day, some questions they are updating like that. Okay, so you have to thoroughly follow the e-medicine and the therapeutic guideline and the other related guidelines for the Australia. Okay, so thank you so much, doctors, for joining the session. Yeah. And if you want cardiovascular module, this all notes, it's like a huge commitment of mine. I have taken like 2 weeks for these notes. And if you want, you can just text me and ask about the more details. I like to, yeah, give everything. Yeah. Thank you so much, doctors.
Thank you so much.
Yeah, thank you. Okay.